Morning, everybody. Today we have the first lecture for hematological overview by Dr. Amr Gawaly, Assistant Professor of Internal Medicine. Definition of anemia. All of you know that the anemia is one of the most common diseases we are facing in the internal medicine. What is the definition of anemia? Anemia is present when there is a reduction in the number of RBCs, red blood corpuscular or red blood cells. Hemoglobin content of the blood will decrease, so the auto carrying capacity of the blood is decreased. All of you know that hemoglobin, the main function is the carrying of oxygen. So when the hemoglobin is reduced, the oxygen saturation in the tissue will decrease, and this is one of the major problem occur due to leading to the manifestation and the complication of anemia. Anemia will be classified according to the etiological. This is the first classification. What is called the anemia? First of all, deficiency of component, which is very important as a raw material to sense the RBCs. Iron, vitamin B12, folic acid. The second cause is aplastic anemia. What's mean by aplastic anemia? Mean that the bone marrow is the factory that senses the RBCs is depressed, and depression of the bone marrow making aplasia or decrease in the function of the senses of RBCs. Hemolytic anemia means destruction of the RBCs, and the hemolytic anemia we have many types. Some of them is congenital and some is acquired. Hemorrhagic anemia is due to excess bleeding, and the excess bleeding occur in the situation of excess menstruation, patient having esophageal varices and having hematemesis and so on. Morphological, according to the blood indices. What's mean by morphological? The size and the shape of RBCs. Size and shape of RBCs. When the size is small and the color of the RBCs is bright red, it's called microcytic hypochromic. Microcytic hypochromic. When we are seeing by the microscope, we are found that it is bright red and small in size. This is occur in the iron deficiency anemia due to decrease in the iron, and in the thalassemia. Thalassemia is Mediterranean anemia. It's a congenital disease, and this patient having a hemolysis, and the size of the RBCs is small and it's bright in color. Normochromic normocytic anemia means that the size of the RBCs is normal and the color is normal. This is occur in the aplastic anemia, in the hemolytic anemia, except the thalassemia, and the acute blood loss. Macrocytic normochronic anemia. What means by macrocytic normochronic anemia? Macrocytosis means macrocytosis mean that the size is enlarged. Normochromic means that the color is the same. Why not the color is increased also? Because the concentration is the same. The hemoglobin content inside the RBCs is increased, and the hemoglobin content increased by the same degree. So the color is the same, not concentrated. This is occur in only one type of the anemia called megaloplastic anemia. And the megaloplastic anemia is due to folic acid and vitamin B12 deficiency. What is the general features of anemia? As we see that the main problem in the anemia is decrease of the oxygen. So the patient with anemia may be asymptomatic sometimes, a slowly falling level of hemoglobin, uh, 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 making the patient not to have any symptoms, because the body is compensated for anemia, and the anemia not occurs suddenly, it occurs slowly, step by step, so the patient not suffering from any problem. uh, sometimes we have symptoms, but these symptoms is not specific, and this is very important because the symptoms is sharing many diseases, not only the anemia making this. For example, fatigue, faintness, headache. dyspnea, difficulty of breathing, palpitation, tachycardia, pallor, uh, yellowish color of the face, tachycardia, and heart failure in the end. The anemia may lead to heart failure, yes. Sometimes when the anemia is severe, it leading to what's called anemic heart failure, because the heart will not found any blood to pump. We will start by the first type, and the most common type of anemia is the iron deficiency anemia. Iron metabolism. Where is the source of the iron? Iron present in the meat, liver, kidney, vegetables, and so on. Requirement 10 milligram per day, but only 1 milligram is absorbed. 10 milligram per day, but only 1 milligram is absorbed. The absorption is increased with vitamin C and decreased with phosphate, phytate, and tannin. So we are advised the patient to taking vitamin C with each meal to increase the absorption of iron. For example, orange, tangerine, and so on, lemon, and to avoid using tea or black tea after the food directly, but we can separate the tea from the food by 2 hours because it will inhibit the absorption of iron. Exercise excretion 1 milligram per day through desquamation of the cell from the skin and GIT. As you know that the skin and our skin and GIT is usually exposed to traumatic surface and traumatic uh, uh, um, conditions and so on. So usually the epithelium is desquamated and then formed again, desquamated and formed again, and so on. Is the most common source of loss of iron from the body. The storage of iron is stored as what's called ferritin, but in the tissue, and part of the ferritin circulate in the body, reflect the iron body store. So when we are doing investigation to diagnose that this patient having iron deficiency anemia, we are using serum ferritin or doing serum ferritin. Etiology of the iron deficiency anemia, usually inadequate intake. It is in the infancy after 6 months. The baby, when he have breast milking from mother, the milk mother or the breastfeeding having a sufficient amount of iron for this baby. But after 6 months, when the baby start to eat by itself, himself, the baby, if not taking sufficient iron, it will be suffer from iron deficiency. Anorexia, patient who are not feeding well, old age, usually the old age also not feeding well, so it may lead to iron deficiency. Decrease in absorption in the diseases, many category of disease called malabsorption syndrome. Increased demand in the pregnancy and the growing children, and uh, nowadays all the guidelines recommend to taking iron for the pregnant woman because the iron stored in for this woman not sufficient for her and for the baby. Chronic blood loss is hemorrhage, especially from the GIT hemorrhage, ulcer and varices and gastritis and so on. So when the blood is lost slowly, drop by drop, or small amount by small amount, the anemia will decrease gradually without bleeding manifestation. Ankylostoma, this is one of the common parasites that making anemia. Vaginal bleeding, females with excess vaginal bleeding will lead to also iron deficiency anemia. Clinical picture, the patient have the general features of anemia, headache and dyspnea and tachycardia and so on. And sometimes we have epithelial changes. The most common is the nail. We have what's called the brittle nail and the loss of luster. Normally we have a luster in our nail. This luster will be lost. Brittle nail is weak and easily broken. Meaning that the shape of the nail becoming spooning or like a spoon. Angular stomatitis is inflammation occur in the mouth, in the angle of the mouth, and this is very characteristic for iron deficiency. Glazed tongue means that the tongue become uh, 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 normally we have a brush borders for the cells over the tongue. The tongue lost this brush border and become red and glazed. Become red and glazed. Clinical picture of the cause: we have GIT or vaginal bleeding. uh, 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 the patient is complaining from this problem, or malabsorption syndrome. This patient can complain from chronic diarrhea and ankylostoma in the investigation, or disturbance, GIT, abdominal pain, frequent bloating, and so on. Investigation. What is the investigation to diagnose iron deficiency anemia? First, to prove that the patient have anemia, hemoglobin uh, doing it will be decreased and the RBCs will be decreased. To determine the types of anemia, usually the iron decrease normally it is uh, uh, 50 to 150 milligram per deciliter. Ferritin is low, and the ferritin is the storage of iron. If we are doing bone marrow, this is the factory for the synthesis of RBCs. We will find it's hyperplasia. The factory is hyperactive to synthesize more and more RBCs. With decreased bone marrow iron stores, we have a special stain can be stain the bone marrow to see if we have an iron store or not. uh, 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 the the third investigation is to determine the cause. So first we proven that we have anemia or not. Second, to diagnose the cause of anemia. Third, to see what is the cause making this anemia. To detect the source of bleeding or blood loss, we are doing upper and lower GIT endoscopy. It will see us if there is ulcer, there is varices, and so on. Stool for ankylostoma, occult blood in the stool. This is means that if we don't have obvious bleeding, we are asking the patient to doing investigation called occult blood in the stool, and this will found if there is a blood in the stool, or also if it is present in a small amount. Treatment of iron deficiency anemia. First of all, treatment of the cause. If you have esophageal varices, you must inject these varices. Peptic ulcer, we are taking a medication for peptic ulcer. Ankylostoma, we are taking a medication for ankylostoma, and so on. The second item is the iron therapy. Sometimes we may need blood transfusion if hemoglobin is less than 7 gram per deciliter and the patient having a severe symptoms, or the patient is we are hurry to elevate the hemoglobin in case of we are doing we are not doing surgery and so on. What is the iron therapy? We are using oral iron called ferrous sulfate or ferrous gluconate. Uh, Usually, the iron having a nausea for the patient as a side effect, and can be avoided by taking iron with food. Ascorbic acid is the vitamin C, can be given to improve absorption, as we see in the natural form like orange or lemon, or it taking in pellets of vitamin C. Hemoglobin level start to increase after 1 week and return to normal within about 4 to 10 weeks. So the to restore the anemia or iron deficiency, we need to take for about 3 months to correct the anemia. Hemoglobin should be raised by hemoglobin should be raised by 1 milligram per deciliter every 7 to 10 days. Duration of the therapy for 4 to 10 weeks till the hemoglobin become normal, and then a smaller dose for about 3 to 6 months to replenish the iron store. So total amount, total time for improving the anemia, it will be 6 months or more. Failure of the oral iron, refractory iron deficiency anemia. Means refractory means that not responding to treatment. Why the patient may taking the drugs and not responding? First, wrong diagnosis. The patient not have iron deficiency anemia, have any other types of anemia. Failure to take tablet, iron intolerance. When he is taking tablet, he have nauseating and gastritis and so on. Malabsorption, or oral tablet not absorbed from the GIT. Chronic hemorrhage. Patient is taking iron oral and the blood is lost from the source of bleeding, so the result is nil. It will not elevate the iron. In this condition, we will taking what's called parental iron therapy. Indication of parental iron therapy: oral iron not intolerance, chronic blood loss, malabsorption when rapid response is required in case of severe anemia. So, any problem making the oral iron not tolerated, we can take the parental iron. Side effect: anaphylaxis or urticaria, but we are taking antihistaminic before we are giving the oral IV iron, and making sensitivity test first before we giving these drugs. Flushing and headache because it sometimes making vasodilation. Preparation for parental iron is iron dextran called cosmofer, iron sorbitol, or iron saccharose called sacrofer. This is the name of drugs. We are taking the iron IV very slowly with saline diluted in 100 milli saline and infused. Second type of anemia is megaloplastic anemia. Megaloplastic anemia, from the name, is the size of RBCs is enlarged. This group of anemia caused by deficiency of vitamin B12 and folic acid. Why the size is enlarged? Usually, the folic acid and vitamin B12 is needed for DNA synthesis. So, when the RBCs is needing to proliferate or replicate or duplicate, the RBCs need the folic acid vitamin B12. When this deficiency is present, the size of the RBCs start to be enlarged to be divided later in, but it cannot be divided. Why? Because the DNA not divided. So lastly, we have a large RBCs just, and no division or no replication, so the anemia will be developed. It's characterized by RBCs with MCV 100 FL, and it may reach more than 150 FL. Vitamin B12 or cobalamin requirement 1 microgram per day. Source usually animal source, so vegetarians will have megaloblastic anemia or deficiency in vitamin B12 and have a risk to developing B12 deficiency. Absorption is absorbed from the parietal cells of the stomach, secrete glycoprotein called intrinsic factor, which combine with vitamin B12. This is very important step. If we have any problem in the stomach making the intrinsic factor not present, vitamin B12 will not absorbed orally, and this is occur in the atrophic gastritis and the patient having a chronic gastritis. So we prefer to give vitamin B12 IV or IM because the intrinsic factor is important to absorption oral, and if it's not present, it will not be absorbed. On reaching the terminal ileum, specific receptors on the mucosa bind to B12 intrinsic factor complex, and the intrinsic factor is not absorbed. After absorption of vitamin B12, it binds to a carrier in the plasma called transcobalamin D. Then it is transported to the tissue. So the vitamin B12 have a carrier in the GIT called intrinsic factor, and the carrier in the plasma called transcobalamin 2. Acid, folic acid requirement about 15 microgram per day. So the amount we are need for the folic acid is more than the amount is needed for vitamin B12. The source is animal food and vegetables. Absorption is duodenum and jejunum, with source stores 5 to 15 milligram. It gives supply for months. So if the patient not taking vitamin B12 for long time, usually the storage present in our body is sufficient for this the patient for 2 to 4 years. But the folic acid, if it decrease, not taking, it's sufficient for the patient for just months, 3 to 4 months. After that, the folic acid will decrease and the megaloplastic anemia will develop. So we are giving folic acid very important in all types of anemia, especially in all types of anemia, especially for males in the pregnancy. Function of the folic acid: amino acid metabolism and DNA synthesis, methylation of homocysteine to methionine. Causes of megaloplastic anemia: vitamin B12 deficiency, decrease intake, and this is very rare in strict vegetarian, and decrease intrinsic factor, and this is one of the important uh, uh, problem making vitamin B12 to decrease. Due to atrophic gastritis, two forms of atrophic gastritis have been described. Type 1 is true autoimmune gastritis, antibodies against the intrinsic factor and making it to inhibit it, and this is what is called pernicious anemia. Type B, it is non-autoimmune and is associated with H. pylori infection. Overall, in these two types, the intrinsic factor will not be secreted, so the vitamin B12 were not found the carrier for him, so it will not absorb. Vitamin B12 deficiency. Also, the causes is intestinal disease, for example, malabsorption, terminal ileum disorder, uh, 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 two diseases like tropical sprue and Crohn's disease. This Crohn's disease is an autoimmune disease making inflammation of the intestine and making the absorption difficult. Tropical sprue is overgrowth of bacteria or infection, making also the absorption is difficult. Vitamin B12 utilized by bacteria in the stagnant loop or by Diflubothrium latem. Diflubothrium latem is an parasitic infestation used the vitamin B12, and the stagnant loop means that patients who are doing bypass operation, we have change in the normal pathway of the GIT, making some site to be stored the food and fermented and allow bacterial overgrowth and prevent the absorption of vitamin B12. Some drugs like colchicine, neomycin, para-aminosalicylic acid, transcobalamin 2 deficiency, also it will not carry the vitamin B12 in the blood. Folic acid deficiency decrease the intake in patients with unbalanced diet, common in alcohol and teenagers and infant. Malabsorption increases demand for pregnancy. It's very important drug in the pregnancy. Some drugs like phenytoin, methotrexate, trimethoprim, and so on. What is occur in the megaloplastic anemia? What is the pathophysiology? Vitamin B12 or folic acid deficiency lead to impaired DNA synthesis and RBCs. Okay? Okay. Arrest of the nuclear maturation, but the cytoplasmic maturation proceed. Size of the cells is increased as the cytoplasm, but the nucleus maturation is arrested, making the cell to be enlarged inside. And the more cell grows, the cells become large with MCV exceed 150 flow liters. Increase the size of the RBCs in the blood and bone marrow, leading to what's called intramedullary. So, number of RBCs is decreased because it is not divided. Second item is intramedullary hemolysis. The size of the RBCs when it enter the spleen or inside the bone marrow, it see that it is an abnormal shape. So this abnormal shape must be destructed. Any abnormal RBCs, the spleen will be destructed. So the anemia from two sources: no division or no proliferation of the RBCs. Second item is the destruction of the RBCs. With the vitamin B12 and folic acid deficient, we will have a leukopenia and thrombocytopenia, atrophy of the rapidly dividing cells of the GIT, neurological manifestation only in vitamin B12 deficiency. Why leukopenia and thrombocytopenia? Because we don't have a folic acid and vitamin B12 for DNA synthesis, so all elements of the bone marrow will be abolished or inhibited to be synthesized. Atrophy of the rapidly dividing cell of the GIT, because the DNA also inside these cells will not be synthesized. So these cells will be not regenerated. GIT cells usually is destructed all over the day because of the gastric juice, GIT juice. Neurological manifestation occur only in vitamin B12 deficiency. What is the clinical picture of the megaloplastic anemia? Vitamin B12 deficiency, we have anemia as general features of anemia as before. GIT manifestation, as we see that there is no sense of the GIT epithelium, so the patient having dyspepsia and atrophic glossitis. Neurological manifestation, peripheral neuropathy and subacute combined degeneration. What's mean by peripheral neuropathy? Numbness in the periphery, and subacute combined degeneration. This is occur in the axonal nerve in the spinal cord. Folic acid deficiency, anemia, GIT manifestation like dyspepsia and glossitis, but in the folic acid deficiency we don't have a neurological manifestation. Investigation to prove anemia, we are doing CBC. We found the hemoglobin is decreased, RBC's count is decreased. To determine the cause, blood in this MCV is increased, but MCHC is normal, and this is very important. MCV is increased, but MCHC is normal. Bone marrow showing increased megaloblast. If we're doing bone marrow, we found that the RBC's size is increased, and this is called the megaloplastic erythropoiesis. To determine the cause, we are needing to doing what's called the gastric function test to see if there is malabsorption or not, the intrinsic factor, and so on. Antibodies against parietal cell for the pernicious anemia or autoimmune disease for intrinsic factor are positive. Folic deficiency, we are measure the level of folic acid. It usually serum level less than 4 nanogram per milliliter, and positive Figlo test. This is not important, okay. Vitamin B12 deficiency, serum level less than 100 nanogram per milliliter, and positive chilling test, not important. Gastric function test, antibodies against parietal cell and intrinsic factor are positive. Cancelled chilling test. Other investigation, serum bilirubin due to increased intramedullary hemolysis will be increased. Mainly indirect because we have hemolysis. Reticulocytosis will be increased. What is the reticulocyte? Reticulocyte is the small RBCs senses in the bone marrow, and these RBCs not functioning well. Uh, uh, Sorry, the RBCs not mature well, so it come to the peripheral blood and it is not mature yet, so the reticulocytes will increase. What is the treatment? The patient is taking folic acid, give folic acid 5 milligram per day till improvement, then lower the dose for maintenance 1 milligram per day. In vitamin B12 deficiency, we give hydroxycobalamin, and this is a vitamin B12 associated with transcobalamin. So giving injection. So you don't know need the intrinsic factor or transcobalamin. We are giving ready for the cells. ELF 1000 microgram IM twice during the first week, then 1000 microgram per week for 6 weeks, then 1000 microgram every 3 months for life. Most of patients require lifelong treatment with parental vitamin B12, reversible cause intestinal bacterial overgrowth or parasitic treatment may reverse this the deficiency. If you see, this is the dose of vitamin B12 because this is one of the common mistake. Use the vitamin B12 excessively, and if we are doing investigation to see the level of vitamin B12, we will found it is exceed the normal level. Thank you.